Hi friends, welcome back to my YouTube channel. This is the second part of puzzles to pertinent use of antimicrobial agents in acute undifferentiated fever. In the previous part, I have described the various causes of acute undifferentiated fever and the definition of acute undifferentiated fever and some simple pointers to diagnosis of this acute undifferentiated fever, especially the tropical fever causes. Now, in the next section or the current section, I'll be talking to you on the various other pointers to diagnosis associated with fever, if there are any other features, how we need to go about in diagnosing this acute undifferentiated fever is what I'm going to discuss.
So as per the description in the previous slide, so here the conjunctival suffusion is here for leptospirosis, half muscle tenderness also in leptospirosis, and contact with contaminated water like sewage and soil and water in the fields mixed with the feces and the urine of animals. So this history points towards the diagnosis of leptospirosis. And here, this particular loop for hepatitis A and D, I have left it blank, but as clinically there are no specific features suggestive of A and E. Now let us come to fever with rash. We know rash and fever caused by SCHED. S is scrub typhus, C is cytomegalovirus or chikungunya, H is HIV, E is EBV, D is dengue. So fever with rash is caused by these 5 to 6 etiological agents. Now the skin rash will come to the center because here it is fever with rash. What are the other specific features? Now this eschar is very characteristic of scrub typhus. So I'll pull this eschar into this and pull this scrub typhus into this loop here, this part where fever and rash is present. And if eschar is present, it's almost diagnostic of scrub typhus. And I push this dengue and chikungunya here and pull this polyarthritis and arthralgia to this. While we have cytomegalovirus, HIV, and EBV to the center where there is skin rash with fever. There are no other specific features in these particular conditions. So now let us try to see. Now, pushing these etiological agents and the clinical conditions into the appropriate loop. They have represented three loops here. So skin rash is common. So the skin rash will come to the center. And now let us see the scrub typhus. We put it here. And eschar, which is very characteristic for scrub typhus, will come here. And the CMV, HIV, EBV will come to the center because there are no other additional features. Dengue chikungunya, I place it here and I push this polyarthralgia and arthritis here to this place because fever with rash and polyarthritis and arthralgia is seen in dengue chikungunya. Fever with rash and eschar is seen with scrub typhus. Just fever and rash is seen with CMV, HIV, and EBV. So let us try to visualize this one by one. So as per my explanation, each one of us, this condition is going into the different parts of the loop. Now let us come to fever associated with sore throat or throat pain. So the etiological agent is VIA. VI is viral etiology and A is group A streptococcal infection. So this fever with sore throat or throat pain is associated with other features. Now, what we need to do is we need to differentiate between viral and bacterial etiology because viral etiologies do not require any antibiotics, only symptomatic treatment, while the bacterial etiology needs to be treated with appropriate antibiotic. Now, I have a host of features. Now, A is high fever with toxic look. B is cough. And then we have C, running nose. Then D, postnasal drip. E is tender jugulodigastric lymph nodes. F is follicles or membrane on the tonsil. G is bad breath. H is nausea and vomiting. Now, this throat represents the viral etiology. You can see the diffuse congestion in the throat, while this represents the bacterial etiology, where there are follicles or membranes on the tonsil. Now, let us try to understand each of this feature, whether it fits into viral etiology or bacterial etiology.
Now, let us see one by one. So, cough is a feature of viral etiology. Any throat pain or sore throat associated with cough is more suggestive of viral etiology. Then running nose again is a feature of viral etiology. So any patient presenting with fever and sore throat or throat pain associated with cough and running nose, they're more suggestive of viral etiology. Then the post-nasal drip again is a feature of viral etiology. Bad breath or halitosis also is a feature of viral etiology. Now here, high degree of fever with toxic look is a feature of bacterial etiology. And the presence of follicles on the tonsil is a feature of bacterial etiology. Then the presence of jugulodigastric lymph nodes and which are tender also is a feature of bacterial etiology. And then nausea vomiting also is a feature of bacterial etiology. So this is how we differentiate the sore throat associated with fever into viral etiology and bacterial etiology. Why am I stressing upon this? Because in viral etiology, you don't need to treat the patient with antibiotics, while in bacterial etiology, you need to identify it and treat with appropriate antibiotics so that it doesn't result in complications like acute rheumatic fever and glomerulonephritis.
Now, friends, combining everything, fever with jaundice, that is Lea in Elosari. So, fever with jaundice, etiology LEA, leptospirosis, hepatitis E and A. Then we have fever with rash. SCHED is a mnemonic for the etiological agents. So we have eschar and lymph nodes, very characteristic of scrub typhus, where you have fever and rash. And polyarthritis and arthralgia is very characteristic of dengue and chikungunya. While this EBV, CMV, and HIV, they just have fever and rash, so they come to the center. Next, we have sore throat caused by virus or group A streptococci. So respiratory viruses or group A streptococci or other bacterial etiologies. Now we have one more thing. A patient with prolonged fever with weight loss, we have to keep tuberculosis in mind. Usually tuberculosis is not of acute onset, but sometimes, very rarely, it can have an acute onset. So tuberculosis, because it's very common in our country, we have to keep tuberculosis as a differential diagnosis for almost every kind of syndromes. Now I have one more puzzle for you. What is the first drug of choice for enteric fever as per latest ICMR guidelines? Place the striker at the right answer dot. And now to clue to find the right answer is the angle BAE formed on the left hand side is 45 degrees. So which of the four? Meropenem, ceftriaxone, azithromycin or cotrimoxazole? So you can make out that the answer is cotrimoxazole. So as per the ICMR guideline, cotrimoxazole is the drug of choice. And in the latest 2025 guidelines, they have also mentioned azithromycin as the first drug of choice. So as per the previous guideline, this puzzle is created. So now you have to place E at cotrimoxazole and measure the angle.
Now, what is the duration of treatment for enteric fever? It is
10 to 14 days. Not 7 days, not 3 weeks or 4 weeks or 5 days. Many people treat the patients for 7 days or 5 days and send them home, and they come back with recurrence. So appropriate duration of treatment is 10 to 14 days. And if you diagnose severe leptospirosis, what is the first drug of choice? It is penicillin G. Although ceftriaxone, doxycycline and azithromycin might help, but the first drug of choice for severe leptospirosis is penicillin G. Now, once you identify the etiological agents, mainly the bacterial etiological agents, what are the important drugs that can be used? So for enteric fever, we have cotrimoxazole, azithromycin, ceftriaxone bar, cefixime used for 10 to 14 days. And for rickettsial fever, we use doxycycline, azithromycin, chloramphenicol for 7 days. And for leptospirosis, penicillin G, doxycycline and ceftriaxone for 7 days. Now what you need to do is, I have given the Venn diagram here and place the antibiotic appropriately in these loops. Now let us see how we are going to place. So cefixime and cotrimoxazole used exclusively in enteric fever. So it will come into this loop and it will not go into the place where there is overlapping space. Next is ceftriaxone and doxycycline. So ceftriaxone can be used for enteric fever, it can be used for leptospirosis, and doxycycline can be used for leptospirosis, enteric fever and rickettsial fever. That's the reason why ICMR says doxycycline is the first drug of choice for acute undifferentiated fever. Next, let us see azithromycin. So this azithromycin can be used in rickettsial fever and also enteric fever. Then penicillin G is given only in severe leptospirosis. Chloramphenicol again only for rickettsial infections you use chloramphenicol. So understanding the various antibiotics, you have to place them appropriately in this Venn diagram. That's why this puzzle is called as where in Venn. I have another simple puzzle for you. Uh, EF represents enteric fever. So to make this E, we have used 5 sticks, and to make this F, we have used 4 sticks. Now convert this E into A using the same 5 sticks. So this A represents amoxicillin and azithromycin, which are useful in the treatment of enteric fever. And here F we have converted into C. See, cotrimoxazole, ceftriaxone, cefatoxime and cefixime starting from C are the other drugs useful in the treatment of enteric fever. So these are the important drugs useful in the treatment of enteric fever. So for you to remember, I have just created this simple puzzle. Thank you for your attention, dear friends. If you're still puzzled, contact me at mnsumana12@gmail.com. Thank you.